You're listening to Online Pet Health Podcasts with Dr. Megan Kelly. Continuing education for veterinarian rehabilitation therapists. Learn more at onlinepethealth.com.
Hey Vet Rehabbers, welcome to the Veterinary Rehabilitation Podcast. I'm your host, Dr. Megan Kelly, and I've got Matt Brunke from the United States on with me today to chat to you about elbow dysplasia. Now, Matt is no stranger to Online Pet Health. He has lectured many times for Online Pet Health members on our webinars as well as our online conferences. And he's also a lecturer at our Vet Rehab Summit, which is going to be at the end of the year. Welcome, Matt. Thanks so much for joining me.
Oh, thanks, Megan. It's great to be here.
Matt and I actually see each other quite often online because we're both members of on the board of the IABRPT. And we're just chatting now because I think they're about to release the dates for Cambridge, and we're actually thinking that they're out on the iabrpt.org website. So for those of you that are interested, Cambridge in 2020 is the IABRPT conference, and the dates are the 19th to the 21st of August. And Matt and I have been helping with the program, and it's going to be absolutely awesome, isn't it, Matt?
Yeah, it's really coming together quite nicely, I think, on both the canine and the equine side. So it's something I'm really looking forward to.
Yeah, I think there are going to be loads of people coming from Europe. So we're hoping that there's going to be quite a mixed international bunch of vet rehabbers at the conference. So for those of you that are interested, we'll put the link in the podcast notes. Matt, before we go on and chat about elbow dysplasia, I thought we could maybe chat about you a little bit. So why don't you tell us about your journey and how you got into veterinary rehabilitation and all the things that you've done. So, I mean, from the time that we first met a few years ago in Uppsala, I think you've added about 3 other sort of credentials after your name since then. So tell us your whole journey from starting off as a vet.
So, it's a fun and winding road. And for me, it was because, to be honest, when I graduated vet school 15 years ago, there wasn't a definitive specialty in rehab. We have the rehab certification. So I graduated from Ross University in 2004 and actually did mixed animal practice for the first couple of years, even though I'd grown up in New York City. So that time of working on equine really helped me to hone my lameness and sports medicine skills. And then I went out and got into general practice in small animal and was able to do FHOs and extracapsular repairs and amputations and a lot of orthopedic surgery, and enjoyed doing that. And so when I got to a practice that already had a rehab department with a couple of very valuable and wonderful veterinary technicians that were already certified, I had the opportunity to go and become a CCRP. So I got certified in rehab and then became the rehab director for that hospital of 10 doctors. All along that way, I kept doing other things because for me, I had thought about doing a surgical residency right out of school, but for a myriad of reasons, I didn't wind up doing that. But in general practice, I was able to take the AO plating courses, the fracture repair courses, the TPLO courses. So I was doing all these things and understanding the importance of rehab in those. And as that developed, I realized that rehab is a great component and the foundation piece to all this movement and mobility disorders, from orthopedics to osteoarthritis to obesity, and then of course into neurological problems. So anything that doesn't walk right was what I kept getting put on my plate, and I didn't have as much time for vaccine appointments and otitis cases, which in my world is fine. I appreciate those that work with those, but if I ever have to see those again, that's totally fine by me. But I realized that rehab needed more. So I learned through the International Veterinary Academy of Pain Management, I learned more about perioperative pain management as well as end-of-life hospice type care, which is really a sad thing to think about, but it's a very important cog in what we do as rehab professionals. Then I realized that, well, the Western world is not the only world to treat pain and movement. So I learned acupuncture and added that in to help my patients. And I just kept this winding, twisting road. Because at least here in the States, the AVMA only recognized rehab and sports medicine as a specialty in 2010. So right around 2000, 2014, I went back and did a career path residency to become boarded, because now I realized that, oh, this is where I need to be. This is how I can help my patients the most and get the most out of my career and help others and learn from others. So I went back and, while working full-time as a specialist, did a residency research project and went back and took rotations, and then just kept pushing forward and learning more and getting good communication across. I mean, Meg, you know, when we get together for an IVRPT meeting, we have 6 continents and 90 some odd countries represented. So we always all keep learning. I got lucky enough that once I had everything done, I was able to pass the American College of Veterinary Sports Medicine and Rehab boards on the first shot. So in theory, I'm done with exams for the rest of my life. And now I'm happy to see that the European College has established a VSMR program, and I want to see more residencies develop. And I realized that, you know, all the things that don't walk right, whether it's canine, equine, feline, or any others, is part of under our umbrella to help those patients. And so all those things are a little bit different, and sometimes we have to learn about kinesiology taping, or we have to learn about joint mobilizations, or we have to learn about stem cell therapy. So it can be a little confusing sometimes, and sometimes it feels honestly a little overwhelming. But the best part about it is that I can take a moment, pause, communicate with globally a bunch of fantastic people, and we keep learning and helping patients to get better at the end of the day.
Yeah, we do keep learning, and I want to thank you, Matt, because you're always sharing your knowledge. So I mean, you do lecturing all over the world. You actually, I think, in a few weeks, aren't you? You're going to China to lecture.
Yeah, I'm really looking forward to this trip. A colleague of mine had been doing some orthopedic lecturing over there, and they were looking for some folks to teach them a little bit about rehabilitation. So I got thrown in as a possibility. And how do you turn down the opportunity to spend time in China? You don't. So I'm lucky that I've got the flexibility in my schedule now to go spend some time there and to meet more colleagues. You know, we'll be presenting 2 veterinarians in a couple of different cities, and looking forward to doing that too.
So you're chatting about earlier, you don't miss the otitis externis. I don't miss expressing anal glands and pilling cats. Those are the 2 things that I really, really don't miss, focusing on rehab. So Matt, I'm going to put you on the spot a little bit and ask you a question. What is it that nobody knows about you?
Oh, all right. So what nobody knows, well, my friends know this one, but a couple of years ago, one of my dive trip on the Great Barrier Reef, and I got down to about 60 feet early on the dive. We were living on a dive boat, and both my primary and my backup regulator malfunctioned. Spoiler alert, I did not die. Spoiler alert, I did not have to wind up. I got lucky. It was early in the dive, so I had to do an emergency surface.
Sure.
But I actually wound up not getting the bends. It was early enough in the dive that I hadn't pressurized myself enough. So yeah, that was an entertaining morning. Never in all my years of diving, and I've been diving almost 20 years, I've never had both my primary and my secondary reg fail. So that was a little bit of a challenge, but I got right back on the next dive 3 hours later and keep pushing forward.
It would be my worst nightmare. Absolutely. I mean, I'm too scared to even dive. I'm too scared. I don't like being under the water. But not being able to breathe is probably one of the biggest things that I'm scared of. So I'm very, very brave. Thank you for sharing that.
Yeah.
Let's get on and start chatting about elbow dysplasia. Now, obviously, it's quite a complex topic to chat about because it's not just one condition. Do you want to break it down for us?
Oh, elbow dysplasia, you know, there's so many different components to it, and I think we're still always learning more about it. We try to break them down into some of the components are going to be an ununited ankylosing process, a OCD lesion inside the joint itself, usually off the humeral condyle, and just fissuring and damage at the the most common one we think about is damage at that medial coronoid process. So some of those surfaces are weight bearing and are going to be really painful. Some of them are not in certain breeds versus others. So Elbow dysplasia is a, to borrow from my friend, I think he's been on, Dr. Ryan Gallagher, neurologist, he calls the cutaneous trunci his fickle mistress. To me, elbow dysplasia is my fickle mistress.
Yeah, I mean, it's one of those things, you either get the cases and they've been diagnosed really early, or you see them and they're a lot older and maybe they were diagnosed and no surgery happened to them. Let's break it down into the two. So let's chat about the younger animal first. So the younger dog that's diagnosed. Do these cases normally go for surgery, or are there times when we would just sort of opt to treat them conservatively?
Oh, that's a great question. And before I can even answer that, I'm going to back it up just a second, because diagnosing these, and you're assuming we've gotten the diagnosis. These are even in young dogs, they're very frustrating and challenging to diagnose. There was a paper out a couple of years ago that compared radiographs versus CT scan versus arthroscopy for sensitivity of diagnosing elbow dysplasia. And radiographs were only about 35% sensitivity. CT scan only hit, I think, about 80%. And arthroscopy was the gold standard at 100%, but how many times can we scope every elbow? So diagnosing these first and foremost is a challenge, but what I've learned in my career is that in a young dog, in any dog, a hind limb non-weight bearing lameness, so a hind limb, is going to be a cruciate until proven otherwise. And what I'd recommend to everyone listening in, because front limb lameness, literally I'll have 6 or 7 consults a day because nobody wants to touch it. In my opinion, front limb lameness is an elbow until proven otherwise. Okay? Even when you're not sure if it's an elbow, go out and go for it and rule out all the others. Be a good Sherlock Holmes and eliminate the other possibilities. But most of the time it's an elbow. So that young 6, 8, 9-month-old Labrador Golden Retriever that comes in limping to your clinic on a Friday afternoon, it's not a soft tissue most of the time. It's the beginnings of those elbows. And I equate it to the iceberg that got the Titanic. We may only see a little bit of soreness, but once we actually get in there, that whole elbow could be massively inflamed or painful or all these other damages that are going to occur. So I think that looking at that is where our first place has to be, is just to make sure we don't toss it up as a soft tissue, put it on NSAIDs for a week, it kind of gets better, and then we don't find it again for 6 months or a year.
Those percentages that you mentioned in that study are quite interesting, because, unlike in the States, here in South Africa, not everyone can afford, or not everyone has health insurance for their pets and can afford to do all the diagnostics. So they might just be x-rayed, and sometimes maybe they aren't even x-rayed, so often we don't get that diagnosis. So doing an MRI or a CT scan in South Africa is sometimes the same cost as basically doing an extracapsular cruciate repair. So when you're looking at the costs of things, is it worth it? And I think that also here, there are not as many people scoping. So you'd have to really refer to a specialist. I mean, I don't know what it's like there, if sort of the average vet scopes, or is that only specialist practices?
It's growing a little bit. Most of the time it's just boarded surgeons that are scoping. I can scope as well as a specialist. And there probably are some more people learning it a little bit, but I don't want to emphasize that in your look at that paper, that's the ideal. I think we also have to be very practical. So, realizing that I feel like sometimes I have twin peaks of clients. I have the clients that come in where money's no object and they want to know everything. And I have clients that we're trying to just be a practical answer in any diagnosis in rehab. I don't want to blow all my money on diagnosis and not have anything left for therapy to make that pet better. So I think a practical way to look at these is do your thorough physical, okay? Rule out everything else. Be really slow and meticulous and patient with that patient. And if the shoulder's not painful, the scapula's not painful, the long bones aren't painful, the carpus isn't painful, the digits aren't painful, the neck's not painful, so it's not a neuro component. Whatever's left has to be the answer. So it's the elbow. In those cases, on young dogs, I still try to get radiographs. to rule out things like panosteitis or to catch an OCD lesion that we might see on radiographs, or an ununited ankylosing process if they're older than 22 weeks, because that's when that should fuse. And sometimes that alone is all I get as a diagnosis, but that helps me to rule out other things, because I always tell folks, I wasn't born on Krypton. I don't have X-ray vision. I can't look at this and go, yep, there's definitely not an OCD lesion there. So I try to be practical, get some films, and instead of giving them a month of an NSAID, I'll give them a week and check them back in 10, 14 days. Because if it was soft tissue, they should get better. They should kind of work their way out of it with a little bit of help. They should not be getting worse. So even if they can't afford the big diagnostics as far as the CTs and the other tests like that, your biggest diagnostic is your brain and your hands. And I think if you have them come back and follow up, they appreciate that. They want to know that they're getting better. And you can start to hone your diagnosis skills, that you're going to appreciate more subtle things and catch those changes.
So let's chat about those ones that now are diagnosed. So we've got a diagnosis. Are those cases usually, do we recommend them to have surgery, or does it depend on what type of elbow dysplasia, what type of condition they have?
It does depend a lot on what component it is there. So let's take some of the less common ones first. Let's say we find an OCD lesion, okay? The way I always relate that to clients is it's a blister inside the joint. And we know that if things are inappropriate, if you have a blister, you have to kind of wait for it to pop and heal a little bit. Well, the cartilage and the bone is not going to heal that way. So if you have an OCD lesion, our best opportunity is surgical intervention. Because until we go in and clean that out and get down to and stimulate fibrocartilage development, we're going to have a problem. I look at those as a surgical one, ideally. Ununited ankylosing processes, more commonly in German Shepherds, but I've seen them get this in Mastiffs a lot lately in the last couple of years. Those are usually big floating chunks, but they're not as much weight bearing. We used to say absolutely take them out. Now I know some of the surgeons are starting to say, well, wait a second, why did it not attach? And is there a way to reattach it? So I know they're looking at that, but I still think the go-to treatment for that is removal. And then the FCPs and the synovitises and stuff are so much harder. I still think it's great to scope them all because it gives us a definitive diagnosis. But it can be a little frustrating if all we get is a lot of synovitis and just minor cartilage erosion. But then we know that. But if we can on the OCD and the UAPs, I think we're really best off with surgery. And we assume that it's elbow dysplasia, but sometimes it's something like where the humeral condyles don't ossify completely. We've had a couple of those in practice in the last couple of years, and those are at risk for fissure fractures throughout the length of the bone. So again, it's a helpful thing that if they're not getting better, even if you don't get it on your initial visit with the client, if they're not getting better in 2 or 3 weeks, at least try to get some well-positioned, sedated, orthogonal view radiographs of both front legs. That's my go-to standard, is get 2 good views of each joint, of each leg, so you can compare. That'll give us our best chance. And then surgery for those. But then honestly, it's a lot of management for the other mixed bag of what's there for a young dog.
And obviously these cases now, I mean, do you usually find that they tend to have ongoing rehabilitation, or is it we sort of rehabilitate them post-operatively and then they come back sort of periodically for flare-ups, and then as they get older, we start to see them a little bit more?
Yeah, so if we take those kids, and usually they are kids, we'll catch them as early as 6 months of age and sometimes even a little younger. And what we have done is the surgeons go in and clean out their job, and then they come to me, and we get into post-operative rehabilitation, and I start to lay some laws down. And some big laws are you cannot get fat, okay? The dog cannot get fat. Dogs carry 60% of their body weight on their front legs. If they have a BCS of 6 out of 9, they're putting an extra 10% on each joint. We can't do that. So I actually aim for all my OA patients, no matter their diagnosis, all my OA patients, I aim for BCS of 4 out of 9. because this way we have some cheat room when they get to a 5. But if they're a 5 and they become a 6, they have problems. And then the surgical cases, usually we graduate them from post-operative rehab between 8 and 12 weeks. But those are the ones that I then set up and I see every 3 to 6 months for the next 2 years. Because especially those young growing dogs, you know, the dog's been frustrated because it hasn't been able to run around. So we want to get them out and moving, but also we have to keep them skinny, and we have to keep daily low impact exercise. You know, they have to get out and walk, not just chase the frisbee or the ball. They need to go out and do stuff so that we can keep them moving and keep them healthy.
Do you recommend hydrotherapy in those cases?
Oh, absolutely. You know, anytime we can work in a buoyant environment where they're weight bearing and still stimulate cartilage development and still stimulate muscle healing and muscle building rather. So I actually like to get these, I have no problem honestly putting some of these kids in the underwater treadmill at 14 days post-op, and I'll cheat even if they just sometimes need to stand because they're young puppies and they're frustrated. I'll just let them stand in the water. You don't even have to turn on the belt. And I'll put them in at a week out post-op if they just need to not be bounding around on hard surfaces. So I love hydrotherapy for these guys to get them up and building muscle and stay buoyant and stay in good shape.
And do some of them go on to sort of long-term plans where they are continually doing hydrotherapy, or do you mainly put them on sort of home exercise programs?
You know, that's another great question, and it entirely depends on the client and the patient. If mom and dad can't do, you know, when I ask them for daily low impact exercise, I say, can you walk your dog 30 minutes once to twice a day, 7 days a week? Some folks can do that. Some folks can't for any set of reasons. So I ask them, well, if you can't do that, then yes, let's continue in hydrotherapy, or we have to continue a home exercise program, because what I always say about elbows is we almost never cure them. And I have to catch myself because I used to say we never cure them. We almost never cure them. And so we're always managing them for the rest of the pet's life. And so the longer that we stay lean, the longer that we stay low impact activity, hopefully then we're going to minimize our chance for flares and discomfort.
So let's chat now a little bit about that older patient. So maybe it was a dog that was diagnosed, maybe it was operated when it was younger. We know they're going to get OA as they get older. Maybe it wasn't even diagnosed when it was younger. And so now it's sort of at that sort of not end stage, but sort of an older dog, and they obviously now are struggling a little bit. What are the challenges that these dogs mainly face in their environments and for the owners too?
So those are another one that I still try to come back and at least get our fundamental diagnostics, because now they're middle age. I've had some dogs come in that were elbow arthritis, in air quotes, as a diagnosis that did not have radiographs. And in the last couple of years, I've had 3 of them be synovial cell sarcomas. So again, going back to none of us are born with X-ray vision, we don't want to make assumptions. So I go through my fundamental diagnostics with those, and these are the ones that usually are a little more sedentary. They have a limp. They're going through an arthritis flare. So I try to look at those and go, where do they fall into that? And are they going to get better with a little bit of an NSAID for a week and get through that flare? And then we're going to manage their other secondary issues, their obesity, their lack of muscle development. But if they don't get better within a week or so on pain medications, now those ones that I might turf back to surgery and go, is there something just tumbling around in here? You know, can we go in arthroscopically and clean out some pebbles and get an idea of how damaged that cartilage is? Because that's going to be our best opportunity to know a little bit. If that's not the case and they are getting better on their NSAIDs, then I'm going to go, okay, here's our 3-month plan. 3 months is we want to get out and walking every day. We want to lose 10% of our body weight, if not more. And we need to get into some strengthening and home exercises and start to do damage control, because we know we're behind now. We're trying to play catch up as much as we can. And if those work, then we're really good and we're managing these kids, but something may change. realizing it's a podcast, what I want to do, people can't see this, but if you think about an elbow as a door hinge, you should be able to close the door all the way and put your hand on your own back. And so if I have a dog who can flex their elbow most of the way, and we're managing this kind of middle-aged dog, and then they come in a month later and I can only flex them, let's say before I could flex them to 45 degrees, pretty good for an arthritic dog. And now I can only flex them to 90 degrees and they're screaming in pain, or they're trying to bite me and they're a sweet, sweet dog. That's the dog that usually has broken off a new chunk. And those are the ones, if something is drastically changed, redo your diagnostics and really have a heart-to-heart about getting them into surgery, because you may not be able to help them if something's really dramatically changed.
And then Matt, what about those cases now that have severely reduced range of motion and now they are starting to get quite advanced? So we're nearly towards those end stage. What can we do for those cases, and what can we recommend?
You know, those are the ones now that we try to look at, and you have to have a good chat with your clients and your surgeons and see what other opportunities there are. Because you may say, well, we're trying our NSAID, we've added in gabapentin, maybe we've done a joint injection, which we can touch on in a minute. But some of those ones, I'm like, well, how much are we going to put into stem cell therapy if we don't know what it looks like arthroscopically? So when we kick them back to surgery, we talk about things like a cutaneous unilateral, not cutaneous, compartmental unilateral elbow. We're kind of do like a mini elbow replacement. Is there something that we can do to help there? It's a mixed bag of results. I think it depends on which surgeon you talk to with those as to who gets good results and who doesn't. But I think it's worth investigating on those. But as they start to get into that scenario of approaching end stage, I have a heart-to-heart and I say, look, my goal here is to minimize the pain, hopefully minimize the limp, but I am not, the pet is always going to have a limp. Those are the ones that now I start to think, how much is the biceps and supraspinatus and other things up in the shoulder now taking a beating? So I'm trying to look at the rest of it beyond just the elbow joint, and the rest of the patient, of course. But now as they start to progress into that, and let's say they're taking NSAIDs every day and they're on other adjunct meds and they're coming for rehab, and let's say surgery is not an option, or we've already had recent surgery and we know that it's down to very severe cartilage damage, maybe a 3 out of 5 or a 5 out of 5 outer bridge score. Those are the ones now that I'll say, you know what, let's do something targeted. Why fight it systemically, especially if it's, let's say it's one elbow and the rest of the dog's pretty healthy, or you have that dog that is getting middle age and those liver values are starting to creep up, those renal values are starting to creep up, and you're like, can I really keep them on carprofen or daracoxib or other things? So those are the ones now I'll start to reach for targeted therapy. Targeted therapy maybe, of course, as part of rehab, we've already been doing laser therapy. We may be doing shockwave. So those are my external targeted therapies. Pulsed electromagnetic field, another good external therapy. But my internal targeted therapies, I usually break down to either biologic or pharmaceutical. Pharmaceutical is usually a combination of hyaluronic acid with some form of cortisone, either triamcinolone or methylpred, into the joint. Or biologically, we're either talking about platelet-rich plasma, autologous conditioned plasma, or autologous conditioned serum, or stem cell therapy. And then even on top of that, there's now even some new kind of hybrid pharmaceutical biologics that are on the research and development side right now that are potentially showing some promising results to help that joint. No matter what I'm trying to do with that, is my goal is get out some nasty old worn out joint fluid, do it in a safe, clean, sedated environment so it's easy and not stressful for the patient. And I'm trying to reduce that synovitis. So anything that I'm going for is my anti-inflammatory, whether it's a steroid or regenerative medicine. And I'm trying to improve the viscosity of that worn out joint. So that's where hyaluronic acid or some of these other things that are out there now are helpful.
In your experience, which of the therapies have you found to be most successful?
Oh, I need to start keeping track of all of them because, to be honest, it's going to depend on the patient. I try to not do big dollar investments, like I said, unless I have a definitive diagnosis. I try not to put $3,000-4,000 worth of stem cells into an elbow that we don't have a recent scope on, because if there's a loose fragment in there, nothing is going to make that better if there's something tumbling around. So I probably get my best results still with methylprednisolone and hyaluronic acid in a joint, but I think that I may be a little biased on that because I probably do more of those than I put in stem cells into those older dogs. So that may be more of just a question of how many patients I've seen that we've used it on. So I still lean a little bit more on those, or I try to lean a little bit more. I'll do platelet-rich plasma injections, and I'll do them once every 3 weeks or so. But if we don't see an improvement after 2 injections, then, okay, this is a patient that maybe isn't going to respond to that. Let's try a pharmaceutical option instead. Because if we think about it, if everyone that's listening to this podcast thinks about the time that you have a headache, some of you might take Tylenol or acetaminophen. Some of you might take an NSAID. Some of you might put a cold pack on your head. Some of you might get acupuncture. Some of you might pour yourself a cocktail, right? Everybody's a little individual. Even though we all have the same receptors, our bodies all work a little bit differently. And I tell my owners that, I'm like, look, this may work, but I can't guarantee it. This is my best results are usually with this. But if you go back and look at like some of the original, in the States, some of the original FDA studies for ibuprofen for people and carprofen for dogs had an 85% success rate, which means 15% didn't respond to it. That's okay, right? 85% did, so that's our chance. So it's a little bit of trial and error with these. So we just have to try and see what works best for the client and the patient, because some of these things are going to be a little more intensive. If we're gathering stem cells, we're going to need general anesthesia. I look at budget with those, and then I also just try to make sure that the injection is not the cure-all. The injection is a step to get through the pain and the discomfort. And then I usually want my owners committing to another 2 to 3 months of regular rehab to build strength upon that. So I try to not inject something unless, in those cases, unless we know they're going to commit to rehab as well, because otherwise we're going to have a quote unquote failure of an injection. The owner is going to get upset and come back, well, that injection didn't do anything. I spent all this money. And I look at them, I go, did you walk your dog? Did you come for rehabilitation? Did you get the 10 pounds off of the chihuahua that I asked you to? And when they say no to all those, then it's not the injection or the clinician's failure. It's a failure of the case. So we have to have a good team approach.
Tell me a little bit about orthotics. Do you use orthotics in these elbow cases?
A couple of different things for them. That, you know, if it's not an unstable joint, it's a harder one for me to say. Most of the time when I think about an orthotic, a carpus or a tarsus are my common areas for those, for long-term use. So I've leaned away from orthotics for elbows. I've had owners do some things like some of the PMF devices now, they can wear a jacket over the elbow so they can have a contact point over the elbow while they're doing it. The other one is I'll have some owners, if I trust the dog and I trust the owners, I'll use kinesiology tape for that contact pain relief aspect, that pain mitigation aspect. But I don't necessarily use an orthotic for an elbow most of the time.
For those end-stage cases, you don't find that they're that helpful?
I really don't. I think that, you know, they can be helpful. I might use something that's neoprene to wrap, because you get the dog who, you know, we buy the really nice orthopedic dog bed, and the dog won't lay on it because it likes the cold floor. So sometimes I'll use something around the elbow that comes down over the shoulders to just give me a little bit of padding to minimize hygromas or calluses or pressure sores. So I'll use it for when the dog's recumbent, but I don't find it helpful in the dog's mobility.
So the last thing I wanted to mention is that here in South Africa, I've actually treated a dog that had an elbow arthrodesis for end stage. And it just had the one side done, and it didn't go very well at all. And have you ever seen any cases that have had an arthrodesis in their elbow? And if you have, how have you managed them?
So personally, I haven't seen those. I've heard, you're not the first colleague to have told me that they've had some that didn't go well. I think the elbow is a very challenging joint, and I think, in arthrodesis, if it's a little Shih Tzu, that dog might do really well or have a chance to, because the leg length is so short. I would be apprehensive about it in a dog with a longer leg length. We're taking away so much mobility, and if you look at the studies that show how much elbow range of motion a dog needs for normal ambulation, and we take that away, I think it's challenging. But I'll be honest, a lot of my arthrodesis patients are challenging. Tarsi and carpi, absolutely. I think that as an alternative to an elbow fusion, I would investigate. There's a number of good practitioners in the United States and overseas now that are doing elbow replacements. And I want to see that further develop. I think that is probably our hope, in that these ones that we may be able to cure. I think we're still early in those, and obviously it's not for every patient. If we're talking, in the States, anywhere from $7,000 to $10,000 with all the follow-up and things per elbow. But I think that hopefully with 3D printing, with some more technology developments on those, that if we can get that might be our ace in our hole to help those patients. The other one that people have asked me about is, well, why can't I just amputate that dog's leg? And those are the ones that I try to keep limbs attached. And I always say most of the time my elbow patients, probably 85% of them are bilateral disease. So those are the ones that, I'll keep trying to manage their arthritis. I'll be honest, I've done methylpred and HA injections every 3 months on top of Adequan injections and regular rehab. And even though some of those dogs, to be honest, I've had them get carts. There's a number of companies that make some really good front wheel carts. And if that is enough for the pet to be outside and having a good quality of life with its family members, and then inside we work on other forms of traction and stuff, those are the ones I would reach for more before an arthrodesis or an amputation.
Yeah, I've had great success with those front wheel carts, especially for them being able to, like you say, go with the family on a walk, because that's really where they struggle. So it just gives them that mobility and a little bit of freedom. Matt, thank you so much. That was such an interesting talk. You always have so much knowledge to share, and I just want to say thank you once again. I know that you're really, really busy. You're rushing off now to go and catch a train somewhere. So I'm glad we didn't go over time. Have a wonderful trip in China. And please take some exciting pictures of you eating strange things. We'd love to see them on Facebook.
Absolutely. And thanks for having me, Meg. I always appreciate it. Take care, everyone.
Thanks, Matt. Bye.
Vet Rehabbers, thanks for listening to my podcast. Don't forget to click the subscribe button, and it would be great if you could leave me a review. I want to know, what are you doing on the 15th to the 17th of November? It is our Vet Rehab Summit, which is our online virtual conference for veterinary rehab professionals. Find out more information at onlinepethealth.com.